Good morning. I'm Craig Hirsch. I'm an associate physician at the Channing Division of Network Medicine and the Division of Pulmonary and Critical Care Medicine at Brigham and Women's Hospital and an associate professor at Harvard Medical School. And I'll be talking about chronic obstructive pulmonary disease, or COPD. Here are my disclosures. The outline of today's talk is shown on this slide. We'll talk about the definition and pathophysiology of COPD, the assessment of COPD patients, treatment of stable COPD, and then a summary and the board review questions. So this definition is from the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, and you see the website URL here. And this is a very good document with extensive information about COPD, which we'll be using for most of this lecture. I have a very long-winded definition shown in your slide, but we'll go through some of the highlights in the next several slides. So one of the important parts of COPD, to define COPD, is using spirometry or pulmonary function testing, and it's absolutely essential to make this diagnosis based on the GOLD document. And I know you'll have a session on pulmonary function testing later today, but this shows on the right here what a normal flow volume loop looks like, and then severe airflow obstruction, which would be consistent with COPD. There are several different pathologies that incorporate COPD, and patients may be more familiar with these terms, such as emphysema. On this side of the screen, you see a normal lung histology slice. So here's an airway, blood vessel, and then the fine alveolar attachments seen in the lungs. In contrast, in emphysema, we see destruction of the alveoli, loss of the attachments, and collapse of that central airway. Chronic bronchitis is another phenotype of COPD, and histologically is shown by mucus metaplasia. In this stain, mucus stains as red, and you see this big plug of mucus in the small airway. And then a higher magnification, you see the goblet cells, each containing mucus, ready to be secreted into the airways. Small airway disease is another important component of COPD. And again, reminder of the nice, thin, small-walled small airway seen here, whereas the COPD airway shows epithelial thickening, fibrosis, but not much smooth muscle hypertrophy in contrast to asthma. So how do these pathologies lead to airflow limitation? So normally we see the airway is held open by the alveolar attachments, mostly comprised of elastin fibers, where in COPD, especially in emphysema, we've lost those alveolar attachments holding the airway open. We have inflammation and fibrosis in the airway lumen, and mucus hypersecretion, all of which lead to airflow obstruction. So risk factors for COPD. In the developed world, the most common risk factor for COPD is obviously cigarette smoke, but we do note there are important effects of other environmental exposures, such as secondhand or environmental tobacco smoke, occupational exposures to dusts and fumes, and both indoor and outdoor air pollution. But over the last decade or so, we've learned there's other important risk factors for COPD, including genetic factors, chronic respiratory infections, and low socioeconomic status has become a major risk factor for COPD in the United States. COPD is a disease of aging, and as the US and the world population ages, we're seeing an increased prevalence of COPD. Next, we'll discuss the assessment of COPD patients. So there's four components of the assessment of COPD patients according to the GOLD document: assessing symptoms, assessing airflow limitation using spirometry, assessing risk of exacerbation, and assessing comorbidities. So the signs and symptoms of COPD are fairly nonspecific, especially in the earlier stages. Symptoms are common respiratory symptoms, including cough, sputum, dyspnea, wheeze, and chest tightness, and these symptoms alone are unable to distinguish COPD from other common respiratory disorders such as asthma. In more severe cases of COPD, we may see systemic symptoms such as weight loss, muscle weakness, peripheral edema, and I would consider depression also a symptom of severe COPD. Similarly, the physical exam is fairly nonspecific, especially in the earlier stages. In more severe COPD, physical exam findings may include a tripod posture with the patient leaning forward with their elbows on their knees, cyanotic changes to the skin. You may notice they are breathing fast, have pursed lip breathing, have a prolonged expiratory phase or accessory muscle use. Patients may have hyperinflation shown by a barrel chest. On auscultation, breath sounds may be distant and wheezes may be heard. Similarly, cardiac sounds may be distant, and in cases with pulmonary hypertension, there may be an increased second heart sound, jugular venous distension, and peripheral edema. Cachexia or muscle wasting can be seen in later stage COPD. Since the symptoms are very nonspecific, there are several test instruments that may be more effective to assess patients' symptoms of COPD. This one is called the COPD assessment test, or the CAT test, which is a series of 8 questions which a patient ranks from 0 to 5, whether they have symptoms such as cough, phlegm, chest tightness, breathlessness, etc. And this is something the patient could fill out in advance of the visit or in the waiting room. The scores are added up, and a score greater than 10 is considered to be symptomatic COPD. This instrument is a bit simpler. It's called the Modified MRC Dyspnea Scale, or the MMRC score, and it's reproducible activities. The patient is asked whether they cause breathlessness. Normal is only getting breathless with strenuous exercise, where the most severe is patients who are too breathless to leave the house or breathless when dressing and undressing. We consider a score of 2 or more to be symptomatic COPD. And that's patients who walk slower than other people their own age, maybe walk slower than their spouse on flat ground, or have to stop for breath when walking at their own pace. That's not considered a normal consequence of age. So next step in the assessment is using spirometry to assess airflow limitation. The GOLD document uses post-bronchodilator FEV1 or post-bronchodilator spirometry to define COPD, but in practice, many people use pre-bronchodilator as well as post-bronchodilator. For simplicity's sake, GOLD defined COPD based on an FEV1 to FVC ratio less than 0.7, and then stage the severity of COPD into these numerical categories 1, 2, 3, 4, or mild, moderate, severe, and very severe, based on fairly arbitrary cutoffs of FEV1 percent predicted. These have really fallen out of utility in the GOLD guidelines for treatment decisions, but both pulmonary function labs may still report these GOLD severities, and patients may read and ask you about them. The assessment exacerbations is fairly straightforward, since we know that prior exacerbations are the best predictor of future exacerbations. And patients may not recognize these episodes as exacerbations. They may be considered bronchitis or a bad cold that triggered prescriptions for either antibiotics and or systemic corticosteroids. This data is from the ECLIPSE study, which was a longitudinal 3-year study of over 2,000 patients with COPD. And in the first year, they asked patients, how many exacerbations did you have last year? Shown in this yellow color is patients with no exacerbations. And then in the second year of the study, they most consistently had no exacerbations. And similarly, in the third year of the study, these patients were most likely to have no exacerbations. Conversely, patients with 2 or more exacerbations, shown in the red color, went on to have 2 or most commonly went on to have 2 or more exacerbations in the second year of the study and 2 or more exacerbations in the third year of the study. Patients with 1 exacerbation in the first year, shown in gray, could go either way, could have an equal chance of having none, 1 or 2 or more exacerbations in subsequent years. So we tend to consider 2 or more exacerbations as a high risk of future exacerbations. So in 2017, the GOLD updated their guidelines to combine all these different assessment measures that we've discussed so far. First is confirming the diagnosis of COPD with spirometry using the FEV1 to FVC ratio of 0.7 that I mentioned. Grading the severity of airflow limitation based on these categories, 1, 2, 3, and 4, based on these FEV1 cutoffs. And then people may be familiar with this ABCD categorization, which is assessment of both their symptoms and risk of exacerbations. Symptoms are shown here on the bottom, with symptoms being marked by an MMRC score of 2 or more, so having to stop on flat ground or walking slowly, or a CAT score of 10 or more, marking high symptoms. And similarly, high risk of exacerbations was that 2 or more exacerbations in the prior year. And GOLD has also added 1 exacerbation leading to hospital admission as a marker of high risk. So then you put these numbers together in both categories and come up with A, B, C, or D, where patients may range from low symptoms, low risk of exacerbations in category A to category D, which are high symptoms and high risk of exacerbations. And the updated guidelines use different drug therapies depending on these different letter grades. So COPD is not the only thing that causes shortness of breath and cough in a smoker. As I mentioned before, the symptoms are quite nonspecific, so we always have to remember the differential diagnosis. Most common in the differential diagnosis would be asthma, and often these diseases may travel together, or patients may state they have asthma because it's a more commonly known disease than COPD. In most cases, asthma is earlier onset, usually in childhood, and patients may have a history of atopy, such as allergic rhinitis. Congestive heart failure is also common in this elderly population of smokers. Physical exam would show findings of crackles and peripheral edema, and pulmonary function tests would generally show restriction and not obstruction as seen in COPD. Bronchiectasis is another consequence of cigarette smoking and multiple other conditions, and that could show airflow obstruction on spirometry. We would expect patients to have a chronic cough and sputum production, and chest X-ray and especially chest CT scan would show abnormalities consistent with bronchiectasis. In areas where tuberculosis is endemic, then that is also an important part of the differential diagnosis for airflow obstruction and respiratory symptoms. Again, we would see characteristic changes on chest X-ray and CAT scan. There are several rarer conditions that may be confused with COPD. Obliterative bronchiolitis may show up in younger patients or non-smokers. It could be related to occupational exposures, collagen vascular disease, and rejection of lung transplantation or bone marrow transplantation. That is diagnosed by air trapping on expiratory chest CT scan with the appropriate clinical history. Diffuse panbronchiolitis is a rare condition in the US, seen almost exclusively in East Asia, where it presents predominantly in male non-smokers who present with dyspnea and sinusitis, and their chest CT scans show small central lobular nodules. Besides spirometry and assessment of questionnaires, there are other tests that may be useful in the diagnosis and management of patients with COPD. Other pulmonary function testing may include lung volumes, which can directly measure hyperinflation, that is a cause of symptoms in severe COPD. A measurement of diffusing capacity is also commonly done to assess gas exchange. Measurement of arterial blood gases is recommended in severe COPD to assess carbon dioxide levels and CO2 retention. And as we know, oxygen saturation, which can be easily measured in the office or hospital, does not tell us whether a patient is retaining CO2, which may change their ultimate course of therapy. The 6-minute walk test is a test done in the pulmonary function lab or in the rehabilitation facility, is just what it sounds like, measuring how long patients, or how far patients can walk in 6 minutes. And it's used to evaluate disability as well as an assessment in pulmonary rehabilitation. All patients with COPD should be tested for alpha-1 antitrypsin deficiency, a genetic disorder which may cause 1% of COPD in Caucasian populations. Testing includes measurement of serum levels of the alpha-1 antitrypsin protein in either genotyping or protein phenotyping. Chest X-ray in severe COPD may show findings seen on this photograph with flattened diaphragms, reduced lung markings, especially in the upper lobes, very narrow cardiac silhouette, and cachexia or muscle wasting. Chest X-ray may only be helpful in the most severe cases. In general, has a fairly low sensitivity and specificity to diagnose COPD, and may be more useful for other diagnoses of shortness of breath and cough in a smoker, such as congestive heart failure or tuberculosis. CAT scans may be much more useful in identifying both the diagnosis of COPD and the different heterogeneous types of COPD. Despite this, CAT scans are not routinely recommended in the management of COPD, though many patients with COPD may also qualify for lung cancer screening and get CAT scans through that indication, or may have shown up in the hospital with these symptoms and had a CAT scan done to evaluate their dyspnea. These figures show two patients with severe COPD at a young age. This patient has profound destructive emphysema demonstrated on CAT scan with almost no normal lung on this slice, whereas this patient shows no emphysema at all, but the chest CT scan does show mosaic attenuation and small central lobular nodules consistent with small airways disease. So these two CAT scans show the pathologies of the slides that we looked at earlier in the talk. It's important to remember that COPD is a systemic disease beyond just the comorbidities that occur with aging. Most common comorbidities in COPD include lung cancer, and it's important to recognize the utility of lung cancer screening in patients with appropriate smoking histories. Patients with COPD may also have concurrent cardiovascular disease, and COPD itself may increase the risk of coronary disease. And remembering that worsening dyspnea and chest tightness in a patient with COPD may have another cause as well. Patients with COPD may have diabetes or metabolic syndrome, osteoporosis, cachexia, and we mentioned depression before. So all of these comorbidities should be questioned about during examination and assessed in the normal manner that is done in your usual practice. So treatment of COPD. There's two main goals of therapy in treating COPD: to reduce symptoms and reduce risk, corresponding to those two different axes on the GOLD ABCD scaling. More specifically, to reduce symptoms, we're talking about relieving symptoms, improving exercise capacity, improving health status, reducing risk by preventing disease progression, preventing and treating exacerbations, and ideally reducing mortality. There are several effective treatments for COPD, first and foremost of which is smoking cessation. There's a role for supplemental oxygen, which we'll discuss further, as well as vaccinations against influenza and pneumococcal pneumonia if appropriate. We'll touch on pulmonary rehabilitation as well. We've known for 40 years that supplemental oxygen reduces mortality in patients with hypoxemia, defined in those initial studies as a PaO2 less than 55 or a SAT less than or equal to 88%, or PaO2 less than 60 or SAT less than equal to 89% with signs of right heart dysfunction or polycythemia. These numbers may be very familiar to most clinicians, as these are still used by Medicare and other insurance companies as indications for supplemental oxygen. For patients who only have desaturation below 88% with exertion, it is not as clear whether supplemental oxygen is useful, although may be beneficial in patients who have symptomatic improvement. We consider this the vicious cycle of COPD. Patients get shorter breath, they reduce their activity, they become deconditioned, which decreases their exercise capacity even more, leading to more dyspnea. And the goal of pulmonary rehabilitation is to break this cycle. So pulmonary rehab is indicated for any patient with stable lung disease with symptomatic dyspnea. It's a multidisciplinary program with a physician, medical director, and then run by either nurses, physical therapists, or respiratory therapists. It usually covers 24 sessions, so over 6 to 12 weeks, so either 2 to 3 times a week. Most importantly is exercise, usually lower body aerobic exercise, treadmill, walking, bicycling, etc., as well as upper body exercise. And some programs also include respiratory muscle training. There's an educational component about COPD, medications, exacerbations, etc. And pulmonary rehab provides an important psychosocial support for the patients who may become more and more homebound as their dyspnea progresses, forces them to leave the house and interact with other patients who may be wearing oxygen and look just like them. And pulmonary rehab has been shown to be very effective in reducing dyspnea, improving symptoms, improving quality of life, and reducing exacerbations. There's a long list of medications for COPD that is updated on an almost daily basis, and we'll go through some of the general principles. So the first principle of COPD treatment is bronchodilators are first-line therapy. There's a strong recommendation for patients with FEV1 less than 60% based on clinical trial data, but should be provided to any patients with symptomatic dyspnea. Most patients are started on long-acting bronchodilators, which could either be long-acting beta agonists or LABAs, or long-acting antimuscarinics or LAMAs. And there's dual bronchodilators that include both LAMA, LABA, which may reduce symptoms compared to monotherapy. But in general, patients are started on a single-acting agent first. In addition to long-acting bronchodilators, all patients should be prescribed short-acting bronchodilators to have for increasing symptoms or prior to exercise. Inhaled corticosteroids are commonly used in COPD, but it is still important to remember that bronchodilators are the first-line therapy. And as opposed to asthma, inhaled corticosteroid monotherapy is never appropriate in COPD. Patients should be considered for inhaled corticosteroids if they have elevated blood eosinophils above 300. And inhaled corticosteroids may also reduce the risk of exacerbations in patients with COPD. There are now several agents that have triple therapy with a LAMA, LABA, inhaled corticosteroid in one inhaler. Should be mindful that inhaled corticosteroids may be associated with increased risk of pneumonia, and due to side effects, chronic oral steroids should be avoided in these patients. This shows the treatment recommendations in GOLD guidelines based on the ABCD groupings, and you'll have this in your course material to review. Roflumilast is an oral treatment for COPD indicated for severe COPD with chronic bronchitis, chronic cough and phlegm in patients with a history of exacerbations. In both studies of patients without other treatments and patients on inhaled corticosteroids and long-acting beta agonists, roflumilast may reduce exacerbations by approximately 15 to 20%. It does have some bronchodilator effect, approximately 50 ml improvement in FEV1, and it is approved as a bronchodilator in Europe. So some patients may have symptomatic benefit as well as the reduction in exacerbations. Azithromycin on a daily basis, 250 milligrams, has been studied to reduce exacerbations in this large study called MACRO, and did show a significant reduction. Chronic azithromycin may be more effective in older patients or former smokers with milder COPD, but we have to be mindful of side effects. Most worrisome in this study was hearing loss, which was generally reversible when the drug was discontinued. There are several surgical or interventional treatments for COPD, including lung volume reduction surgery, which is indicated in patients with upper lobe predominant emphysema and low exercise capacity. There are now several devices for bronchoscopic lung volume reduction, shown by this one-way valve here that allows air to exit the lung, the alveoli, but not enter, leading to collapse behind the valve and volume reduction. And then lung transplantation is reserved for patients with severe COPD as well. So to summarize, COPD includes emphysema, large and small airway disease. Spirometry is absolutely essential for the diagnosis, and we should incorporate a multidimensional assessment, including symptoms, airflow limitation, exacerbation risk, and comorbidities. There are several, quote, tried and true treatments for COPD, first of which is smoking cessation. Others include supplemental oxygen and pulmonary rehabilitation. Principles of pharmacotherapy to remember is that bronchodilators are first-line therapy, and that could be either a LABA or a LAMA or combination therapy. Inhaled corticosteroids should only be used to add on or in combination with bronchodilators, and to consider roflumilast for frequent exacerbations and azithromycin in selected patients. and referral to specialized centers for more advanced surgical and interventional treatments if patients qualify. So here are our board review questions. A 65-year-old male, current smoker with a history of coronary artery disease, gastroesophageal reflux disease, and allergic rhinitis presents with exertional dyspnea and cough. Differential diagnosis includes COPD, asthma, pulmonary fibrosis, congestive heart failure, or all of the above. So we'll give you a few minutes to vote. Okay, we'll move on to the next slide. So yes, the correct answer was all of the above, which almost all of you got, which is very good. So the take-home point here is COPD is not the only cause of dyspnea in a smoker. So in this patient, if we wanted to diagnose COPD, we would perform spirometry to make that diagnosis. Asthma, even in this age group, is definitely possible. This patient especially has a history of allergic rhinitis, and we may do spirometry pre and post bronchodilator to make the distinction between COPD and asthma in this patient. Pulmonary fibrosis also presents in this age group. PFTs would not show airflow obstruction, but would more likely to show restriction, and we would find abnormal findings on chest X-ray and especially chest CT scan. And again, a patient with coronary disease of this age group is at risk for congestive heart failure, which we should be able to distinguish on physical exam and follow up with imaging studies such as chest X-ray and echocardiogram. Here's the next question. 65-year-old male, current smoker, presents with cough and exertional dyspnea, MMRC grade 2, so he's short of breath, has to walk slower than other people or stops on the level. He has required antibiotics once for bronchitis in the past year. His FEV1 is 55% of predicted, and FEV1 over FVC ratio is 0.6. First-line treatments include A, a LAMA, B, ICS-LABA combination, C, nicotine replacement therapy, D, all of the above, or E, A, and C only. I'll give you a minute to answer. Okay, we'll move on to the next slide. So many of you said A and C which answer E, which is correct, and several did say all of the above, and we'll go through those reasons why the A and C are correct. So if we use our GOLD guidelines based on this patient's lung function of FEV, so reduced FEV1 FVC ratio, confirm the diagnosis, FEV1 of 55%, puts them in GOLD 2, and then based on their symptomatic dyspnea, but only one exacerbation in the past year, they would be in GOLD category B. Oh, there they are. So bronchodilators are the first-line therapy for group B, and it could either be a LAMA or a LABA. And then if they have persistent symptoms, considering a LAMA-LABA combination. So that was why the LAMA was correct in that answer. We reserve the inhaled corticosteroids for patients with frequent exacerbations in group D, although I did not mention this patient's eosinophil level, which would be important to know. Smoking cessation is essential for all current smokers, and that's why nicotine replacement therapy was listed on the slide. And again, we should assess this patient's comorbidities as well as assessing their COPD. So here are some references that should be in your packet, including the GOLD website, as some other documents, and I thank you for your attention.
Great, brilliant, and terrific timing. We've got a time for a quick question. Here are two quick questions. One, is clubbing part of COPD?
Yes, clubbing can be seen in any severe lung disease as well as lung cancer. Again, it's a non-specific finding, and we generally think it's patients with profound hypoxemia, but just like the other physical exam findings, fairly non-specific for making the diagnosis of COPD.
All righty, thank you very much.